I hope you are ready to run this race through all these anomalies. We will start with aberrant right subclavian artery, which originates directly from the distal portion of the aortic arch as the fourth branch, and it passes posteriorly to the trachea toward the right arm. To visualize the course of the right subclavian artery, begin with the 3 vessels in trachea view, tilting the probe toward the fetus's right shoulder. The PRF should be lowered, or a bidirectional power Doppler should be used. Under normal condition, the right subclavian artery passes in front of the trachea and extends toward the fetus's right arm, forming a characteristic S shape. The subclavian artery and vein typically appear overlapping. An aberrant subclavian artery can be detected as early as the first trimester and throughout the second trimester using color Doppler. It appears as a vessel originating at the junction of the aortic arch and ductus arteriosus, coursing posterior to the trachea toward the right shoulder. In this case, the right subclavian artery loses its typical S shape and the artery and vein are separated. The azygos vein, which runs posterior to the trachea before draining into the superior vena cava, can sometimes be mistaken for an ARSA. However, unlike ARSA, the azygos vein doesn't originate from the aorta. It terminates in the superior vena cava, doesn't extend toward right shoulder, and displays a typical venous waveform. Similarly, the left brachiocephalic vein can be misinterpreted as the right subclavian artery because it also crosses the thorax from the left to right, passing anterior to the trachea, showing the same flow direction. To avoid misdiagnosis, it is essential to assess both the anterior and posterior region of the trachea, as demonstrated here. By carefully examining the area behind the trachea, we can identify a vessel located posterior to the trachea, corresponding to the ARSA, and another one anterior to the trachea, which correspond to the vein. In more than 20% of cases, ARSA is associated with additional anomalies. Therefore, a referral scan should be performed along with fetal echocardiography. Pregnancies presenting with ARSA and additional sonographic anomalies or markers suggestive of trisomy 21 should be referred for invasive prenatal testing. In such cases, chromosomal microarray analysis is also recommended, as pathogenetic copy number variations have been identified in approximately 18% of non-isolated cases. Conversely, isolated ARSA is more appropriately considered a soft marker for Down syndrome rather than a standalone indication for invasive testing. The risk of Down syndrome based on screening results should be re-evaluated, and if not already done, cell-free DNA testing may be considered to decrease the chance of aneuploidy. When isolated, ARSA should be considered as a normal anatomical variant. Now we move to the right aortic arch, an abnormal position of the aortic arch which crosses the right bronchus and runs to the right of the trachea. The position of the aortic arch is determined on the 3 vessels and trachea view. A right aortic arch is diagnosed when the transverse aortic arch is located to the right of the trachea. When both arches are on the right of the trachea, they join in a V-shaped configuration on the right side of the trachea without forming a vascular ring. This anatomical arrangement is known as the right V sign. This is a mirror image right aortic arch with the brachiocephalic vessels arising in mirror image branching to the normal left aortic arch. This type is less frequent, but it is frequently associated with cardiac defects, particularly conotruncal anomalies. Conversely, when the aortic arch is on the right and the ductus arteriosus on the left side of the trachea, they encircle the trachea, creating a so-called U sign. It is considered a loose vascular ring. In almost all cases, there is an aberrant course of the left subclavian artery arising from the region of the junction of the ductus arteriosus with the descending aorta, called the comerel diverticulum, with a retrotracheal course. The incidence of chromosomal anomalies and pathogenetic copy number variations, particularly the 22q11 microdeletion, is increasing in fetuses with right aortic arch. Although the risk is higher when associated anomalies are present, it remains significant even in isolated cases. Therefore, invasive testing for fetal karyotype and CMA should be offered even in isolated cases. Symptoms occur in approximately 25% of cases, but typically they are not present at birth. As a result, isolated cases do not require delivery in a tertiary referral center. Now we move to the double aortic arch, which is a rare condition. In this case, both right and left aortic arches are present. The ascending aorta splits into two arches which join at the level of the descending aorta. The most common arrangement is with hypoplasia of the left aortic arch. The ductus arteriosus commonly has a left-sided course. The use of color Doppler is a major tool to reach a correct diagnosis. When both aortic arches are normal in size, on the 3 vessels and trachea view, 3 arches instead of 2 are visible in an upside-down N configuration. The ultrasound diagnosis is challenging when the left aortic arch is narrower than the right one, and in 50% of cases is hypoplastic. In this not rare case, the double aortic arch may be wrongly interpreted as a right aortic arch. The largest series of 79 prenatally detected cases of double aortic arch has been recently published. The result of this study confirmed that double aortic arch is typically an isolated abnormality. However, a referral scan and a fetal echo are necessary to rule out associated intra- and extracardiac anomalies. In non-isolated cases, karyotyping and chromosomal microarray analysis are recommended due to the significant risk of 22q11 microdeletion. Currently, there is insufficient data to determine the exact probability of associated genetic anomalies in isolated cases. Nevertheless, although the risk appears low, it is not negligible. Therefore, the option of an invasive diagnostic procedure should be offered to the couple. Although only 5% of neonates with double aortic arch develop symptoms severe enough to require neonatal intervention, delivery at a hospital with appropriate neonatal care is advisable. Now we go on to talk about persistent left superior vena cava, which originates at the junction of the left jugular veins with the left subclavian vein and reaches the lateral edge of the left atrium wall and drains into the coronary sinus, resulting in its dilatation. The normal coronary sinus is barely visible on the four-chamber view. When the coronary sinus receives the venous return through the persistent left superior vena cava is dilated and becomes readily evident on the four-chamber view. To demonstrate the whole course of the coronary sinus, a posteriorized apical four-chamber view should be obtained, slightly tilting the transducer toward the diaphragm. It is visible as a conducting the groove between the atria and ventricles. The dilatation of the coronary sinus may lead to a false diagnosis of atrioventricular septal defect, since the atrial septation is not visible on the four-chamber view. Significant dilatation of the coronary sinus may result in ventricular disproportion. On the 3 vessels and trachea view, 4 instead of 3 vessels are visible, even if we have to be aware of a rare variant in which the right superior vena cava regressed. In these cases, 3 vessels are still present, but the superior vena cava is located to the left of the pulmonary artery on the 3 vessels and trachea view, rather than its typically position on the right. Color Doppler is not essential for the diagnosis. However, on the 3 vessels and trachea view, if the PRF is slightly reduced, both vessels should demonstrate flow in the same direction, opposite to that of the aortic and ductal arches. As shown here, there is no connection between the 2 superior vena cava due to the absence of the brachiocephalic vein, which fails to develop in these cases. And this could be an important hint for the presence of a persistent left superior vena cava. The entire course of the persistent left superior vena cava up to its drainage into the coronary sinus can be visualized on a left parasagittal plane of the thorax. A recent meta-analysis demonstrated that this anomaly is significantly associated with intracardiac and extracardiac anomalies. Therefore, a referral skull and fetal echo should always be performed. In cases where persistent left superior vena cava is not isolated, invasive prenatal testing is recommended, and CMA should always be considered. The challenge lies in the management of isolated cases. The likelihood of chromosomal abnormalities is low in these cases. As a result, karyotype analysis is not routinely performed in these cases, particularly when first trimester screening indicates a low risk of aneuploidy. However, given the significant association with the coarctation of the aortic arch with anomalies that may only become apparent during follow-up, ongoing ultrasound and echocardiographic monitoring is advised. Additionally, a neonatal assessment, including echocardiography, is essential to rule out postnatally the development of aortic coarctation following ductal closure. Now is the turn of interruption of the inferior vena cava. The interruption is at the intrahepatic level, and the continuation in most cases is with the azygos vein which drains into the superior vena cava. Less often the continuation is with the hemiazygos which drains into a persistent left superior vena cava. In an axial plane of the upper abdomen, we can note the absence of the inferior vena cava and the demonstration of another vein side by side to the aorta. This sign has been termed double vessel sign, and it is also present in the 4-chamber view posterior to the left atrium. At the level of the 3 vessels and trachea view, 3 arches instead of 2 are visible, with the 3rd arch on the right of the aorta connecting to the superior vena cava, showing an opposite direction of flow to that of the aortic and ductal arches. On the other way round, where there is an hemiazygos continuation, the 3rd arch is on the left of the ductal arch, draining into a persistent left superior vena cava. A parasagittal view of the abdomen and chest confirms the absence of the inferior vena cava entering the right atrium, and additionally, this view can demonstrate the azygos vein parallel and posterior to the descending aorta with an opposite direction of flow. Although the interruption of the inferior vena cava can occur as an isolated finding, it is more commonly associated with left atrial isomerism. Therefore, a referral skull with fetal echo have to be performed. The presence of a viscerocardiac heterotaxy and the association with cardiac defect are suggestive for left atrial isomerism. However, to diagnose for sure this condition, the presence of 2 atrial finger-like appendages, as you can see here, is fundamental to reach the correct diagnosis. However, this evaluation is not always feasible in prenatal life. When a left atrial isomerism is suspected or diagnosed, fetal karyotype is not required because chromosomal anomalies are almost always absent. However, the pros and cons of carrying out an amniocentesis to perform a CMA and possibly an exome sequence should be discussed, as isomerisms increase the risk of ciliopathies. In apparently isolated cases, there is no strong indication for the fetal karyotype. In isolated cases, prognosis is typically excellent. An echocardiographic and ultrasound follow-up should be warranted in order to detect possible late-onset anomalies. Now we move on to the persistent right umbilical vein. What happens is that the left umbilical vein undergoes atresia while the right one remains patent. PRUV can be suspected on the axial view of the upper abdomen during the abdominal circumference measurement based on an abnormal curvature of the umbilical vein. Normally, the left umbilical vein curves to the right and connects to the left portal vein. Conversely, the right umbilical vein curves to the left towards the stomach and connects to the right portal vein. This curvature is a subtle sign and can be easily overlooked. A simpler and more reliable method for identifying the right umbilical vein is by assessing the position of the gallbladder, which is located between the stomach and the umbilical vein. Color Doppler enhances the visualization of the umbilical vein's curvatures in case of right umbilical vein. It is crucial to distinguish two different forms, the intrahepatic and extrahepatic. The intrahepatic form is the most common. An extrahepatic persistent right umbilical vein is described as coursing anteriorly on the surface of the fetal liver until it connects directly to the right atrium or to the inferior vena cava, as you can see in the video clip on the right side of the screen. Right umbilical vein is very often an isolated finding. However, an association with other anomalies, especially cardiac defects, has been described. Therefore, a referral scan and fetal echo should be performed. But when present in isolation, this abnormal finding not seem associated with a higher incidence of chromosomal aberrations. Therefore, parents should be reassured. And finally, the last one, ventricular septal defects. The comprehension of the septal anatomy is fundamental to describe and classify the VSDs. The best perspective is throughout the right ventricle. Four anatomic components of the ventricular septum exist: the inlet, outlet, trabecular, and membranous septum. And VSDs can be located anywhere in the interventricular septum. Many classifications have been proposed, but the most common subdivide the VSDs in perimembranous of the inlet and outlet portion and muscular types. Muscular VSDs can involve the inlet, trabecular, or outlet portions, and they can be single, multiple, and they range in size from 2 millimeters to several millimeters. On the 4th view, we can explore the muscular and inlet portion of the interventricular septum. Sonographically, the VSD appears as an interruption of the septum, and the shunt color Doppler is typically bidirectional. What we have to try to pick up are large VSD because the spontaneous closure is unlikely. Small VSD are often missed on prenatal ultrasound. This is not a big deal because they are usually not clinically significant. However, we have to pay attention because very often these defects are not true defects but artifacts. A hint of the presence of a true defect are the borders of the VSD, which are typically echogenic. These small VSDs are often visible only with the use of color Doppler imaging. Inlet VSDs are located in the region of the atrioventricular valves. Careful assessment is essential as dropout artifacts on grayscale ultrasound can result in false positive diagnosis. To better evaluate the integrity of the septum, the suggestion is to insulate the inlet region at a 45 angle. When inlet VSD is truly present, the atrioventricular valves typically appear at the same level. Outlet VSDs are visible only in the 5-chamber view. The first clue to its presence is the interruption of the continuity between the ventricular septum and the medial wall of the ascending aorta. Care should be taken in ruling out the malalignment. If the septum is correctly aligned with the anterior wall of the aorta, then the defect will be defined as a simple perimembranous outlet defect. For many years, VSDs have been reported in association with aneuploidies, especially trisomy 21. However, this seems to be true only for inlet VSDs. Isolated muscular and perimembranous VSDs have a similar risk to those of normal pregnancies. Therefore, in all these cases, the karyotype is not mandatory in case of low risk at combined tests or cell-free DNA. Moreover, there is now attention to understand the association of VSDs with submicroscopic and monogenic disorders. A recent study demonstrated that CMA yields an additional diagnostic rate of 6%, and the most commonly identified anomaly is the 22q11 microdeletion. Therefore, chromosomal microarray should be at least discussed with the couple. Finally, it is important to reassure the couple spontaneous closure of VSD occurs prenatally or within the first year of life in approximately 80% of cases. And as already mentioned, this is only unlikely if the defect is very large. Thank you for your attention.